and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamigam. This podcast comes with a warning. For those of you who have PTSD from your high school physics classes, we will be discussing Young's modulus. And if you have not thought about Young's modulus since your high school physics classes, do not fear. You are not alone. I will walk alongside you asking questions with my own rusty recollection of high school physics. The manuscript we will discuss today is Identification of a Distinct Monocyte-Driven Signature in Systemic Sclerosis using Biophysical Phenotyping of Circulating Immune Cells. It was recently published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I'm excited to be joined by the first author of the manuscript, Dr. Alexandru Emil Matei. Dr. Matei completed his medical training in Bucharest, Romania, and subsequently joined the group of Professor Jörg Distler at the University of Erlangen as a PhD student. He completed the work we are discussing today as part of the fulfillment of his doctoral degree. After he graduated, he began his medical residency at the University Hospital Erlangen and is now developing his research group at the Clinic for Rheumatology and Hillia Research Unit of the University Hospital and Heinrich Heine University, Düsseldorf. Welcome to the show, Alex.
Thank you so much, Vicky, for your invitation and for the kind introduction. I'm delighted to be doing this podcast today and to discuss with you some of our findings and to bring back to the audience some notions of physics, hopefully in a more pleasant clinical context.
So, Alex, I'm going to start actually with the physics with a quick refresher on Young's modulus. So Young's modulus is a measure of elasticity, and the higher an object's Young's modulus, the more stress is needed to create deformation. So metal, for example, has a very high Young's modulus compared to a squishy material like silly putty or Play-Doh, which has a relatively lower Young's modulus. With that in mind, the tool you used in this study to investigate the immune cells from scleroderma patients was real-time fluorescence and deformability cytometry, or RTFDC. I had never heard of RTFDC before looking at your work. Can you tell our listeners what that is?
Sure. The example you mentioned actually illustrates very clearly what Young's modulus is. At the cellular level, the level that we are interested in this study, differences in squishiness of cells are much more subtle. RTFDC is a technique developed by the group of Professor Guck, who is now the managing director of the Max Planck Institute for Science of Light and Max Planck Center for Physics and Medicine in Erlangen, Germany. And we did the study in collaboration with his group. In RTFDC, cells are pushed through a small channel of a microfluidics chip that is approximately the size of a blood capillary. As the cells flow through this channel, they are deformed due to hydrostatic pressures and shear stresses without coming in contact with the walls of the channel. A camera takes pictures of these cells at a very high frame rate as they flow through the channel, and these pictures are then used for further analysis. A contour of each cell is derived, which is further used to determine the so-called biophysical parameters that I will refer to throughout our talk, such as cross-sectional area of their cells and their deformation. Deformation meaning how much a cell would deviate from a perfect circle. Young's modulus is then derived computationally and measures directly the elasticity of a cell. Is a more direct measurement than the deformation because the deformation can depend on the area, as bigger cells get exposed to higher shear stresses and deform more than smaller cells, even if they have similar elasticities or mechanical properties. With RTFDC, we can characterize both cell morphology, such as area, and cell mechanics, such as Young's modulus. Furthermore, RTFDC has 3 lasers and 3 fluorescence detectors that allow immunolabeling, identification of certain cell subsets in a heterogeneous samples by their marker expression. One of the most interesting features for RTFDC was that measurements can be performed in a high throughput manner, up to 1000 cells per second. This sets RTFDC apart from other techniques that characterize mechanical properties of cells, which are several orders of magnitudes lower and cannot be used in the clinic. For this study, we measured 10 to 20 samples per day, each sample with thousands of cells, which we considered a very good throughput, for example.
Amazing. So I really appreciate that explanation. So it sounds like this is a type of flow cytometry, which I think many people are familiar with. So it tells you both which cells are present and then measures kind of how squishy those cells are. Can you tell us a little of the background, the previous studies that use this technique to assess leukocyte activation? And what was it that made you think this would be useful for evaluating immune cell activation in scleroderma?
Certainly. It is a rather new technique. In the first version, in an earlier version that did not contain the fluorescence model, it was published in 2015. Since then, it is extensively used and cited around the world and has the original publication has almost 600 citations. And several of these studies that are using this technique characterize circulating leukocyte subsets. And these studies show that leukocytes can change their biophysical properties due to their activation, for example, as a response to an infection or in hematologic cancers, and that these changes might be a phenotypical adaptation of the cells to their changing needs when they become activated. For example, leukocytes can stiffen and become larger, which would cause them to flow slowly through the capillaries, or they can soften, which can facilitate their extravasation. So there seem to be a direct link between immune cell activation and the physical properties, which sparked the idea that leukocytes might change their mechanics and morphology, not only in response to infection or malignant transformation, but also in the context of autoimmunity, which led then to systemic sclerosis.
Yeah, no, and it makes sense now that you explain it that way. So let's talk about how you set up this experiment. So you were analyzing peripheral blood mononuclear cells, or PBMCs, from 66 patients with scleroderma, 59 patients with rheumatoid arthritis, 28 patients with ANCA-associated vasculitis, and 22 controls. What can you tell us about those patients and their demographics, disease duration, disease characteristics?
So all these patients were diagnosed with their respective diseases according to the latest EULAR and ACR classification criteria. They were donors with an age around 55, with a slightly lower age in healthy donors and slightly higher age in patients with RA, with a ratio of female to male around 2:1, with a disease duration of around 6 years for systemic sclerosis, 4 years for rheumatoid arthritis, and 7 years for ANCA-associated vasculitis patients. And regarding disease characteristics, I would focus on patients with systemic sclerosis. We did not enrich for a particular subgroup of systemic sclerosis patients, and we rather included most of patients with systemic sclerosis, which fulfill the classification criteria. And thus, our patients have a relatively broad spectrum of manifestations of systemic sclerosis, including patients with high disease activity or extensive skin or lung involvement and what end of the spectrum, as well as patients with stable disease or only mild or skin or lung fibrosis. We have about 10% of the systemic sclerosis donors with progression of skin fibrosis within 6 months prior to these measurements, and 25% of donors with systemic sclerosis with progression of SSc-ILD within 1 year prior to these measurements.
Great. And so when you were selecting these patients, was there sort of a selection criteria, or was this just a convenience cohort of what you had in your biobank?
We include patients that fulfill this classification criteria for the respective diseases without further inclusion criteria in the order of their visits in the outpatient department of the Clinic of Dermatology and Immunology in Erlangen. And we only excluded patients that have overlapped disease of, for example, systemic sclerosis with myositis, or patients with active infections or malignant tumors. So we included mostly all the patients that came within a certain time frame.
Okay. And you just had a single time point of collection for each patient, is that correct?
Yes, that is correct.
When you analyze the data, this experiment obviously generated a lot of data. Can you tell us what you saw in the cells from the patients with scleroderma compared to those with the other autoimmune diseases, RA and ANCA-associated vasculitis, and the control cohort?
Certainly. We saw several changes in biophysical properties of leukocytes, subsets in systemic sclerosis compared to controls. However, not all of them are specific to systemic sclerosis. For example, an increase in cross-sectional area of T cells was common for SSc, RA, and AAV. We interpreted these changes due to shared mechanisms between the disease, for example, related to inflammation and not directly associated with pathogenic mechanisms specific to systemic sclerosis. And in this study, we focused on SSC-specific changes. For example, NK and NKT cells had higher cross-sectional area only in SSC patients, whereas monocyte subsets have higher deformation in SSC and not in RA or AAV patients.
And you then kind of looked deeper into the data from the scleroderma patients in a couple different ways. And I kind of wanted to go through each of those in turn. So firstly, specific to the scleroderma patients, was there a correlation between the biophysical properties of the cells and disease activity scores?
Yes, indeed. We observed, for example, a positive correlation between the area of classical and intermediate monocytes and disease activity as measured by the Eustar Activity Index. Thus, patients with active disease have a higher area, which might mean that the cells were tended to be retained in the capillary, which might promote, for example, their margination, which is required for future extravasation. So might be directly correlated with an activated phenotype of monocytes.
Yeah. And so you told us earlier that you had this kind of interesting distribution of patient disease activity. So let's talk a little bit about skin scores. We all know that skin scores are imperfect. But did you see any correlations between the cellular biophysical properties and skin scores in the patients?
We observed indeed an association between biophysical properties of monocyte subsets and modified Jordan skin score. Both cross-sectional area and deformation of the monocyte subsets were positively correlated with the modified Jordan skin score. The changes can be interpreted in a similar way to disease activity, and indeed, the disease activity index is driven to a certain extent by the modified Jordan skin score.
Yeah. No, I get it. And there's always going to be a little bit of confounding there. How about pulmonary fibrosis? I know you looked at that in a couple different ways. What did you find there?
So we first classified patients according to the extent of lung fibrosis as patients with extensive ILD, which have fibrotic changes in over 20% of lung area observed on HRCT, or FVC under 70%, or patients with limited ILD that had percent fibrosis under 20% on HRCT, or patients that had no ILD. And all monocyte subsets had a lower heterogeneity of cross-sectional area, deformation, and Young's modulus. This might mean that in patients with extensive lung disease, some subpopulations of monocytes that might be profibrotic or pro-inflammatory are lost. This is a rather speculative conclusion at the moment, but might help for the interpretation of the result. We also saw that DLCO can indicate the extent of lung fibrosis. That DLCO that is a good indicator for the extent of lung fibrosis in patients without pulmonary arterial hypertension was worse in patients with a low heterogeneity of area and deformation, which goes in the same line with the previous findings. And in line with this, patient that had worsening of lung fibrosis, illustrated by increase in the extent of fibrotic area measured on HRCT or an FVC decline in the year prior to the measurement, had a lower heterogeneity of deformation as well, but they also had an increase in Young's modulus of monocytes. This might mean that the loss of heterogeneity might rather help to categorize patients that have a severe lung involvement, but might not capture patients that have an active lung remodeling, whereas Young's modulus seems to be changed only in patients with active lung remodeling.
Yeah, I wonder whether also some of it may depend on the time point in disease that you're evaluating patients, which kind of gets us to our next question. You know, we know in scleroderma, microvascular changes are important. And so when you looked at pulmonary hypertension and digital ulcers, were you able to draw any conclusions from that? And do you have on these patients capillaroscopy scores, or is that something that you're measuring in your clinic and could correlate with these deformability measurements?
We included an analysis of patients with prominent clinical manifestations of microvascular disease in systemic sclerosis, that's patients with active digital ulcers and pulmonary arterial hypertension. However, we did not evaluate capillary scores. We also observed association of these manifestations, for example, between monocyte area and digital ulcers, or between heterogeneity of deformation or Young's modulus and pulmonary arterial hypertension. However, these studies are rather underrepresented. We did not have too many patients with these manifestations.
Yeah, it seems like it's going to be something we need to look at further. I wanted to highlight two other experiments that you presented in the manuscript that I think are important for the integrity of the science. You did evaluate the reproducibility of the RT-FDC measure, and you also ran some experiments using healthy control cells and assessing whether you could modulate the cell biophysical properties by exposing them to scleroderma patient serum and by exposing them to TGF-beta. Could you tell us about the results of those experiments?
Certainly. These were interesting results for us. First, to evaluate the reproducibility of the measurements, we performed the second measurement of monocytes from the same donor and PBMC isolation in the same day for 9 healthy donors. And we observed a high degree of overlap between the distributions of the physical properties that we talked before, so area, deformation, Young's modulus, between these repeated measurements for all donors, confirming that these measurements are reproducible. In the other set of the experiments that you mentioned, we treated monocytes in culture with TGF-beta as a key profibrotic mediator and with interleukin-6. And we also treated with serum from patients at the two extremes of severity. First, patients with active disease and extensive progressive ILD, and second, patients with stable disease and without ILD. We observed that TGF-beta can induce an increase in Young's modulus of monocytes, whereas interleukin-6 does not induce significant changes. We also observed that only serum from the patients with active disease and extensive progressive ILD induced changes in biophysical properties of monocytes. Those were an increase in Young's modulus and decrease in heterogeneity of deformation of monocytes. These are changes that align to some extent with changes that we observe in the patients. For example, patients with extensive lung involvement and with extensive and progressive lung involvement have higher Young's modulus and a lower heterogeneity of deformation of monocytes. These might suggest that these changes might be due to autoantibodies or profibrotic cytokines in the serum of these patients.
Yeah, really interesting, and kind of brings me to the $1 million question. What does this all mean for the patients? And is this methodology ever going to be something that we could bring closer to the bedside, to the clinic evaluation of these patients?
So for the patient, this means that we have a method now to evaluate that provides access to information that we did not have access before. So we cannot access via flow cytometry, for example. It's a method that for the physician, that for them doesn't involve invasiveness. We are talking just about a normal blood prelevation. We are talking about a technique that can be done in a relatively high throughput manner. So for the patients, they might expect that when the physician is employing such a technique, he might get further information that might help to refine the classification of the severity, so the stratification of the risk of the patient, and might eventually also help to evaluate response to treatment.
Yeah, and it would be great if we could get to that point for scleroderma, for sure. So, Alex, I really appreciate you taking us deep into your work. I wanted to spend a few minutes, if it's okay with you, talking a little bit about your career. You have had this interesting journey. You did your medical training in Romania and then moved from Romania to Germany to do your PhD. Could you tell us a little bit about that move and what prompted it? How difficult was it to make that transition in your life?
Sure. So I got excited about rheumatology during my rotations for my MD studies in Romania, where I went in contact with Dr. Karina Mihai, who was leading a USTAR group there, a USTAR center. There I had contact with lots of patients with systemic sclerosis, and I found also from a clinical point of view very interesting, but also in the meaning of experimental research. So I really felt like there is a lot of research that can be done there with very interesting approaches. And I felt like I want to do more than just clinic, and I want to do also experimental work. So I was interested to follow a PhD position. I was aiming for Germany from the beginning. I think also at the recommendation of Dr. Mihai, I learned about Professor Tistler and his group, and further I read about his publications, which were very interesting, high impact, and with focus on experimental work for systemic sclerosis. And I applied there, and I can say that I was lucky to get the position relatively.
Yeah. He's obviously one of the great scientists in our field. I wondered if you're willing to share, what has it been like working alongside him?
It was an amazing journey. We were developed both. So me as from the starting physician with basically no experience in the lab when I started like 6.5 years ago, and him also from the level of a professor and the group leader to now a clinic director in Düsseldorf, and me to a postdoctoral fellow and starting in the group as a physician and now a group leader in Düsseldorf. I think an amazing journey where I had contact with a lot of collaboration partners, with a lot of amazing techniques that I was never dreaming to hear about basically when I was in Romania.
Yeah. And as somebody who's now kind of through to the other side of this, do you have any tips for listeners who might be just starting their PhD programs, or for other physician scientists who are trying to complete training both in clinical practice and then also at the bench?
So I can say that it is a very challenging path, but it's a very gratifying path as well. So I most certainly recommend physicians to try to do this and to learn about basic research and try to take the information from there and see how they can apply it to learn something new that can be useful and translate this to the clinic. I believe this is basically driving progress in medicine for several years, and we continue to do so. So I think it's a very gratifying path, but expect several challenges and be prepared for that.
Yeah, no, I think that's real, right? It's not an easy path, but it is a very rewarding path for sure. Alex, I wanted to thank you for joining us on the show. It has been an absolute pleasure having you and hearing about your journey so far. And I really look forward to hearing more about your work, particularly in regards to scleroderma, in the years ahead.
Thank you. It was a pleasure from my side as well.
Yeah. So in this episode, I also want to thank physician scientists who bridge the bench and the bedside. They bring very unique experiences and skills that drive biomedical research forward. And while it's a long and arduous journey and easy to lose focus, I do want to encourage all the MD PhDs out there to keep going, because the intersection of patient care and cutting edge science is such a great place for innovation. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACRheum on social media and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.